Thank you. You guys can hear me okay in the back? Front? Okay, good. Thank you for the opportunity to speak. My name is Marty Hogan. I'm a dentist at Loyola. I'll get into that in a second. And thank you for the opportunity to speak to you guys this afternoon. I know it's a little bit late in the day, so I had a few updated slides, and one of my main objective that I highlight was to keep everyone awake. Okay, so I will do my best. So we'll go through some things here. But anytime Stephanie reaches out, my answer is always yes, so thank you so much for having me. We're close by, so if anyone needs anything afterwards, you know, I have my email on there, happy to talk to you or have you into our clinic. Okay, so we'll talk today about some things that we might find in the oral cavity mostly, surrounding scleroderma. Okay, so like I said, I work at Loyola just down the street. I'm going to move around a little bit just so I stay active as well. So we have a dental department within the hospital, and a really kind of cool thing is that we get to train dental residents as well. So in addition to having a dental clinic there, we have 6 residents that come through every year, and I'm in charge of the residency program. So this was last year's group. This is our current team. We have 6 residents every year, and starting next month we have a new group coming in too. So it's a lot of change, it's exciting, and it's really neat too that we get to expose young dentists to different things in the hospital and being able to manage different things. So that's something we're really lucky to have. Okay, I don't have any disclosures here. We will talk about, or I'll show you guys some products and things like that. I don't have any investments in the companies. It's just giving you guys options and things that I've learned from other people and been told by patients that work pretty well. So I'll just pass that along to you guys. Okay, so none of it is, you know, because I'm getting things from the company. So I did add up here in yellow was keep everyone awake. So that was my main objective. So I added that in there, but you guys can see what we'll talk about here, just some of the most common findings and ways that we can help you, ways you can help yourself, and then some unique things. Okay, so there's 3 slides that are my favorite slides. This is one of them. Just to really stress that it's a team effort, and you know that, especially from some of the amazing speakers earlier today. It's a group effort to manage patients with complex medical conditions, scleroderma being one of those, but no matter what your condition is, it takes a team of people to really take good care of you. Okay, so just keep that in your mind always, that you are the leader of your team, you're the quarterback of your team, and so you know, we need great communication between everyone, and you as the patient need to feel comfortable with everybody on your team. Okay, so we get spoiled a little bit at Loyola if all of the team members, all of the managing providers are under the same umbrella, sometimes in the same hospital. That makes it very easy. But if you're in the community or you live in a small town, that doesn't make it impossible. And especially nowadays with all the different ways of communicating, having meetings over Zoom, being able to communicate in so many different ways, that really shouldn't hinder us that much. Okay, so it really takes excellent communication from everyone on your team. That's why this is one of my favorite slides here. And you know your team might consist of some things mentioned here in addition to many more. Okay, so let's dive into some of the most common oral findings. There are a whole bunch, but we'll really try and focus on maybe 5 or 6 of those that we see in a lot of patients that we treat. Okay, so xerostomia, fancy word for dry mouth, and caused by the destruction of the salivary glands. So those are little glands that produce your saliva or your spit. Okay, it causes trouble if you have dry mouth, your ability to eat, speak, chew, a lot of those different things. So a lot of medications reduce your salivary flow, and if you don't have enough spit or no spit, it really puts you at risk for a lot of these things. Your spit is really, really important. It's really gross, but it's really important. Okay, so we could have a whole talk, or I could have a whole talk, sit in this chair and talk about how important your saliva is, but that's for another day. But it's really true, and it's one of those things where sometimes you don't know what you have until it's gone. Okay, so your spit, I think, can fall in that category. So we do have some ways to help if you do have a decreased or no salivary flow. There's a lot of things out there. Some of them are really easy, like water. Okay, I'm trying to point my ball right there, and that's easy to have, and it's something that you can carry around all the time. There are some substitutes to sprays, gels, and rinses. And there's a lot you get those over the counter. You can have prescriptions for some of them, but again, there's access to a lot of those, okay? Water is very easy, like I said. Drinks, gums, lozenges, as long as they're sugar-free. Okay, that's a big thing, because if you're constantly using these things to help with your saliva, but you're introducing sugar at the same time, then we're kind of counteracting, okay? And in really extreme cases, we do have medications that we can use to try and stimulate saliva, okay? So just some products, we don't need to spend too much time. Towards the end, I have a case study or case report to kind of walk you through a patient, so I really want to get to that, and I know we want to keep things moving here. So some of the products, I won't spend too much time, it's just to show you. I always wander the grocery store and the Walgreens or the CVS just to see what's out there when I'm there with my kids. Like, do we have to go again? Because we always make a lap through like the oral health or oral hygiene aisle, just to see, in all honesty though, so that I can speak to like the cost a little bit and just new stuff that's out there. Okay, so we take a lap and see what's out there. So these are all pretty recent. You can see price tags. It's just, I think this is Walgreens. And again, just to show you different, these are a lot of sprays and rinses. There's lozenges, there's toothpaste, so many different things. Okay, there's gum, all of these different things that are out there. Okay, again, I don't have any investment in these companies. None are significantly better than the others, so you can just try a lot of different ones. Okay. What do these do? So it depends on what it is. A lot of these are just for kind of stimulating saliva. Yeah, so it's good for dry mouth. Yeah. And again, one of my favorite slides here too. So as far as a rinse goes, the one thing you really want to make sure is alcohol-free. Okay, because alcohol will really dry out your tissue. And a lot of mouthwashes and mouth rinses have alcohol that gives you like that great burning feeling that we really like to make it seem like it's working, right? And you rinse and you swish, you spit out, and it feels great. A lot of times that's the alcohol drying out your tissue even more, okay? Which if you have a normal salivary flow, your body recovers that quickly, and it's really not that big of a deal. So that's okay. But if you have a decreased saliva flow or no saliva flow, and you use something with alcohol, it's kind of a double whammy. Okay, so alcohol-free mouth rinses is huge. If there's one thing, if you don't remember anything from this talk and you remember this, then that would be gold. Okay, I really mean that. It's that important. Okay, and a couple of really good ones. Crest Pro Health, they are alcohol-free, and ACT. Okay, so ACT is a really important one. ACT has the highest amount of fluoride that you can get without a prescription. Okay, so we can write you a script for a mouth rinse with really high fluoride. ACT is the one that has the highest amount of fluoride that you can get without a script. Okay, and again, this one here, zero alcohol. Okay, so alcohol-free with high fluoride, awesome stuff. Okay, this is a spray that was given to me actually by a rheumatologist at a Scleroderma conference, and he had it like in his pocket. He was like, "Hey, have you ever seen this?" I said, "No." And he goes, "Well, this is a new product. Someone gave it to me, and I thought of you, so I wanted to give it to you." So this is in my bathroom. I just took a picture of it, and we have given it to some patients at the hospital to try, and they said that it works pretty good just to kind of lubricate the tissue. Again, it's for dry mouth. Okay, so that's something that you can get. And we can also mix you up different mouth rinses. Okay, so we do that a lot at the hospital, and it doesn't work like this. One that we did the other day on Thursday, was for an individual who was undergoing chemotherapy, and they had really bad ulcers in their mouth, really painful ulcers, to the point where they couldn't take their pills every day. So they're taking PO medication pills, and ulcers in their mouth that were so painful they couldn't swallow their pills, and so we mix them up something with some viscous lidocaine. We have all these different things we can add in just for palliative care to make them feel better, kind of numb up the area, to be honest with you, so that they could swallow their pills. Okay, sometimes the patients have a fungal infection, We can throw in nystatin. If there's a bacterial infection, we throw in tetracycline, different things. So sometimes it's a combination, and pharmacies can mix that up in a bottle, and patients can try it. Okay, so that's kind of an extra thing that your dentist can do for you. Okay, and this is a really great one too. Again, in my bathroom. Prevention mouthwash. So I use this one actually, and we use it in our house sometimes if you have a sore in your mouth, or our little guy plays sports, and sometimes he'll bite his lip or something like that and bite his cheek. And so this was given to me by a friend of mine who's a pediatric dentist, and he swears by it. So the Amazon drone drops some off at my house, and it works really well. And so we've been giving it to patients at the hospital as well. Okay, so you can get this on Amazon. I haven't been able to find it as much as I roam the aisles at local stores. I can't find it anywhere. You can find it on Amazon in 2 seconds. You type in prevention mouth rinse, it pops up, click on it, it's at your porch 8 hours later. It really is, and so it's great. It's alcohol free, again, just to go with our theme, and it really soothes the tissue. So it's a great product, and it comes, I think, a bottle of 4 was I think like $16, something like that. So reasonable. Okay. Getting back to kind of our main common findings: dysphagia, difficulty swallowing, and this is caused by atrophy of the muscles of the esophagus. Okay, so your muscles contract in a sequence to kind of move food down, and if your muscles have been weakened, it can lead to issues with getting the food down. It can also be from the dry mouth. Okay, so sometimes, again, it's a double whammy of atrophy of those muscles plus really dry mouth. And so if you go to some of the different departments in the hospital and they're testing you for your severity of dry mouth, a lot of them use what they call like the cracker test. And they'll have you eat a cracker, okay? And if you have severe dry mouth and you try to eat a cracker, it's really difficult, right? Has anyone tried that or can relate to that? I see people nodding, right? And so that's like a bedside clinical test that they can do like pretty quickly, just to gauge, right? And they'll say, okay, can you please eat this cracker? And so if you have really dry mouth, that can be a big challenge. So the difficulty swallowing can be from the muscles, but can also be from the dry mouth. Okay, that's something we just chat about when we see you. Limited mouth opening is a big one. A lot of times collagen gets deposited in the connective tissue, leads to fibrosis, just like in the other organs, right, that people have talked about. And it can lead to progressive limitation of opening. Okay, so key word there is progressive. A lot of times it gets worse. It progresses. Okay. And we always measure, so we have different ways that we can measure. In our clinic, you'll see these rulers, and they're just made out of paper. It's like a one and done. We just toss them, we have bags of them, okay? If you want to get fancy, you can use a little gauge, and it all does the same thing, okay? So just to measure your maximum opening, and we want to make sure that if we're seeing you frequently, that number doesn't go down every time we see you, right? Or over the course of months and years, okay? And that can sometimes play into decisions that we make with treatment, okay? Because if we need to I have big hands and fat fingers, and sometimes getting that in mouths of kids or people with a really small opening can be a challenge. So think about trying to get big hands plus an instrument all the way to the back, right? And some people might experience that even just with flossing and brushing. Right? Sometimes it can be tricky. So limited opening is a big challenge for everyone involved, people as patients and as providers. Okay. To move along here, widening of the periodontal ligament. So the periodontal ligament is almost like if you think of a sock that fits over your leg. Okay, so it surrounds the root of the tooth. If this is a tooth, you have this periodontal ligament if we were to put like a sleeve over top of the tooth. And it kind of helps connect the root of the tooth to the surrounding bone. Okay, and it also acts as like a shock absorber, okay, for your teeth. And we don't really know what causes the widening of the periodontal ligament. We just know that it's a really common finding in patients with scleroderma. And all of our dental residents that come through our program, they take their board exams just before they're graduating dental school. That is like a textbook classic board exam. Show an x-ray. like this, and it says what would be your most likely, top of your differential diagnosis. A, scleroderma. B, and the answer is always scleroderma. It's that common. It's kind of textbook. So it can lead to mobility of teeth because it helps lock the teeth in the bone. And if you have this little space here, so that's what it looks like. Normal would kind of look like this. We don't need to be like X-ray experts, but just to give you an idea. So you see that little black line, right, that goes around. If you can see here, it's a little bit wider, right? You see there's a gap. If you compare that one, it looks like a little hairline, whereas here, it's wider. People see that, right? And so this tooth here would very likely be more loose, more mobile than the tooth right here. And also, if you have this little gap, bacteria can get down in there, okay, and lead to infection. All right, so this is just a broader scale X-ray showing a lot of the same things: widening of the PDL, loss of bone, all these different things. Okay, so what do all these things do? Put you at an increased risk for periodontal disease, which is gum disease, and decay, which are cavities. Okay, so it's primarily related to the severity of the dry mouth. Like I said, dry mouth is really a challenge for patients and for dental providers. Okay, saliva is so important to everything. Okay, so we might get you in for more frequent follow-ups. Usually, for a lot of people, go see your dentist every 6 months, get your teeth cleaned. We might want to see you more frequently. Early intervention, and we might be more aggressive, especially with a limited opening. If we notice that that's getting worse. And a lot of times hygiene can be affected by manual dexterity. Okay, so a lot of times patients with scleroderma and other conditions, sometimes their manual dexterity, ability to use their hands can be compromised, and that can be difficult to get to those back areas of teeth and to really do kind of fine motor things so you can't clean the areas appropriately. Okay, so how can your team help you? It's really not, it's not rocket science. So we can keep a closer eye on you, right, and get you into clinic more frequently, and make sure that we're all on the same page, right? Going back to like that first slide about like teamwork and communication, it's really simple. We maybe overbrain a lot of things, but we try in our little dental team to subscribe to the KISS principle, right? Of like keep it simple, silly, or keep it simple, stupid. Don't overbrain it. If we're worried about something getting worse quicker, we're going to see you more often. That kind of makes sense. If you have dry mouth, we'll give you ways to help your dry mouth. The easiest one is water. Okay, so we don't need to overbrain it a lot of times. If things are getting real bad, then sometimes we need to be aggressive and creative, and we have a team of people there that can help us. We're really lucky in our department. We have oral surgeons, we have prosthodontists, we have dental specialists, in addition to people that have been working in the hospital as a dentist for years and years and decades. We can put our brains together and try and help you, okay? Knowledgeable staff, okay? Hygienists, assistants, front desk, dental residents, and make sure, I don't even want to say little things because they're not little things, but things that a lot of people might not know, right? We have warm blankets, we have gloves, we have appointment slots that we can get you in to really help with things that your condition might throw you for a challenge, okay? And the ability to coordinate treatment with other experts, that's automatic, has to be automatic, okay? How can you help yourself? We're going back to that same word, okay? And this here too. So if there's 2 words in this whole talk that you can remember, 3 of them actually: communicate, dry mouth, and alcohol-free, okay? Detail and consistency with your practices, healthy lifestyle, that again is a no-brainer. And then little extras, so we'll talk about some of those little extra things here, okay? Help with toothbrushes, so again, with the dexterity, okay? A bigger handle can help, and sometimes electric brushes. Nowadays, again, this electric brush here, Walgreens brand, $10, okay? Or people will be glad to take your $70 or $120 for the Sonicare Water Pick XL5, whatever. You can use whatever you want. It doesn't matter. People say, should I get an electric brush? If your dexterity or your ability to clean your teeth with a manual brush is not at the level that we need it, then yes, an electric brush is a really good option. If you're able to brush your teeth with a manual brush appropriately, and we teach you how to do that, then that should be just as effective as an electric brush. Okay, so it's completely up to you guys what you choose to do, but electric brushes are great. They do help people a lot. Okay, some of them have the timer, and they have the little sensor where if you're like pushing too hard, it like vibrates, it like literally tells you exactly what you need to do, like 30 seconds on each quadrant. Okay, and if you push too hard with pressure, it vibrates, so you let go a little bit. It's almost like those cars that drive themselves. So it's, which is really great, right? A lot of options out there. We provide these in our office if you need them as well. Okay, get creative with the handle. Wrap it with elastic bands, foam. These are ideas that residents came up with, and just anything to make the handle bigger, right? If you have a hard time grasping a little handle, make the handle bigger. Tennis balls. One of our hygienists would use tennis balls often for people with rheumatoid arthritis, a lot of different things where manual dexterity might be an issue. Okay, implants give us, you know, a lot of great options, the ability to restore function and aesthetics, great long-term success, and it gets better every single year. Okay, so dental implants are an option, and a couple quick research studies here just to show you. Some people will get referred to the hospital and say, my dentist told me I cannot get dental implants because of my scleroderma. And that statement is not accurate. There might be other things, you know, going on in your mouth that might not make you a candidate for implants, but saying you have scleroderma, you cannot have dental implants is not accurate, okay? In this study here, talking about Sjogren's, so a lot of the patients in the study had scleroderma. High implant, these are kind of the key points from the study, it's 2017, so not that long ago. High implant survival rate, low marginal bone loss, which means that the implants were settling into the bone, and low biological complications, so no infection, no redness, no tissue irritation, things like that, okay? Another study here, 2019, they took patients with autoimmune diseases who had oral manifestations, okay? So issues secondary to their autoimmune disease, and the main ones in this study were lupus, scleroderma, and a few of these other ones here, and basically the take home was patients with the above mentioned diseases, you know, can benefit from implant supported prosthesis. So basically we put the implants in, they're like screws in the bone, and then we build teeth on top of them, okay? And so, you know, the outcomes were no different in this patient population versus healthy patients. Okay, so again, just to show kind of what implants are, they're essentially a screw that goes into the bone, and we drill them in, and then we can build teeth on top of them. Okay, so it looks gross, but it's really not. It's, you know, we're having better options every single day. Yes?
How would you know if you're a candidate for implants?
That's a good question. So the question was, how do we know if you're a candidate for implants? So two things, a clinical exam, so we look at the area, and then x-rays. Okay, so it might be a dental x-ray, it might be a CT scan, might be a Panorex that we can take. So all those different things, we kind of put the two pieces together, clinical exam, imaging, and then make a decision. So ways to improve maximum opening. You can use tongue depressors, which are like the popsicle sticks that they, you know, stick your tongue and say, ah, and they push down. You can stack those up, and it's really cheap, and it's easy to use, and it does a really good job. Okay, so this is Emily, one of our current residents. She agreed to take a photo demonstrating how to do it. So this box of like, I think it's 500, we have a whole room filled with popsicle sticks in the hospital to give you a box if you need a box. And again, you might stack up to start, if you have a limit open, you might stack up 12. Okay, so you stack them up like this, and then you put them in. And then you just wait it out. So we always tell patients when you're starting off early on, pick your favorite show, so whatever your favorite show is, and put your popsicle sticks in that commercial, and leave them in for the commercial. So that's like an easy way to remember as far as timing. So pick your favorite show, every time it goes commercial, grab your popsicle stick, put it in there. A couple days later, add another popsicle stick. A couple days later, add another one. And get to the point where you don't have pain, right? But you're hopefully, you know, increasing your number of popsicle sticks until you find your sweet spot, and then you just keep that, okay? Same thing with like brushing your teeth. People say, how long should you do it? Your brush will tell you, but the easy way is like a song. So pick your favorite song. Songs are usually 3 to 4 minutes. And that's how long ideally you should brush your teeth. People say that's crazy. It might be, and my wife thinks I'm crazy. She's like, why do you brush your teeth for so long? And I don't listen to songs, but I really make sure I'm gonna get them good. But if you brush it for the length of a song, that's an accurate way to do it. So very gentle, we don't even talk about brushing it. But Emily shows you how to stack popsicle sticks here. Okay, so that's great. We can also prescribe you a device. Okay, so we have Therabite on the left, Orastretch on the right. I have never personally prescribed an Orastretch. Okay, have some friends that do that, so that's why I listed it here. Therabite, we give out a lot of these at the hospital, not give them out, we prescribe a lot of them, okay? Following surgeries for the joint or people with limited opening, okay? And they both do the same thing. There's like a little fork, looks like a horseshoe that you put in your mouth, and then you squeeze a little lever right here. There's the hand thing right here, and it opens. Okay, so you put them in, and then you squeeze the lever, and it opens. It's just a stretch. It's like an exercise machine for your mouth. Okay? Here's a case report. Our case report here, just real quick here. So it was a 42-year-old female, I'll breeze through this a little bit quick, was referred from a neighboring institution in the Chicagoland area. Reason for coming in, dental pain, and she thinks all of her teeth need to come out. Pain and chronic infection, multiple infections from the teeth in the 2 months leading up to the time we saw her at Loyola. Okay, medical history, multiple autoimmune disorders. So a lot of people will probably nod their head. Sometimes the autoimmune disorders come in groups, so you might have more than one. And so this individual here had Scleroderma and RA, okay, and rheumatoid arthritis. Medications, Imuran, which is common in the RA population, steroid, and then she's taking pain meds very, very frequently because of related to her oral pain, not systemic, okay? So comprehensive exam, all these letters and whatever, that doesn't mean much, but just so the slide wasn't super long. Extra oral exam, tenderness to palpation on both sides of her joints. When we're doing our clinical exam, we're feeling around, she would wince. Terrible, terrible pain in the joint, angle underneath the chin, intraoral, extensive decay, severe gum disease, mobility of all the teeth. We could move literally with our fingers and wiggle all the teeth, okay? Oral cancer screening was negative, fortunately, so that was great. Maximum opening, we always measure, like I said. For me, could get her open to 22 millimeters, which is not much. Our normal, like, quick check, I said I have fat fingers and big hands, right? Normal opening for a lot of individuals is 35 to 40, we usually say, millimeters. And so for me, that's like a quick check when we're evaluating someone in the emergency department and the residents will do a quick check, you know, Mrs. Jones, can you open as big as you can for me? And like, it's a quick 3 fingers, that's about 40 millimeters for me. So, okay, that's like a quick check, okay? 22 was like my thumb, okay, very small. And oral surgery could only get her to about 19, so a little bit less, and a lot of pain on opening, okay? Here are just some of the x-rays, again, showing severe bone loss, that widening of the PDL, okay? And again, generalized decay, chronic infection throughout the mouth, all the teeth were mobile, severe, severe, severe dry mouth where her cheeks would stick to the outsides of the teeth that were remaining. Okay, super, super dry, and a lot of pain everywhere. Okay, so just some of the options that we presented and discussed, we recommended that all the teeth would come out. Okay, so extraction of all the remaining teeth, and then fabrication. First plan was upper and lower dentures, okay, plates that you take in and out. Second one was 2 implants on the bottom, put a plate that snaps into that, and then a plate on the top. And then last one was extraction of all the teeth, implants on the top, implants on the bottom, and something that she cannot take out. Okay, something that's screwed in there. Okay. We sent her to oral surgery as well for evaluation for her joint. And the reason for this case report is just to kind of walk through the reasoning and to show that it's a team effort, right? So the actual decisions don't really matter, but just the thought process. And we ended up treating her in the OR, okay, because of her limited opening and so much work that needed to be done. Doing that in the clinic, even if it was under IV, we're able to do IV sedation for a lot of patients. We didn't think that that would be in her best interest. Okay, so took the patient to the OR and got everything done in one visit, which was kind of nice. Okay, so under general anesthesia, extraction of all the teeth, and then they did a procedure for her joint as well. So it's where you take a needle, basically remove a little bit of fluid in the joint, and then inject some medication. Okay, so that's what this process is here. So after healing, we gave her a little bit more time to heal. and made upper and lower dentures. Okay, so this is after surgery, just to show kind of that when you don't have teeth in your mouth, everything kind of sags down. Okay, so your teeth, even if it's a denture, gives you that good, nice, full feeling, right? Otherwise, everything collapses in, okay? And that's what she looked like afterwards, before we fabricated dentures, okay? This is just to show her tissue healed up amazing. It was pink and firm and no infection, no redness. And again, before there were teeth all around here, right? And this healed up, we gave her an extra couple months. Normally we'll tell patients 3 or 4 months and then we can make you dentures. We gave her 6+ just to make sure everything was healed up. We weren't like a super big rush. She wanted teeth ASAP, obviously. But we were on the same page of like, okay, if we give this an extra couple months, hopefully we'll avoid some stuff down the road. Okay, so she was in agreement. This is her lower arch, same thing, healed up nicely. Try-in with her teeth. And again, you can just see this like looks more full, right? Not kind of collapsed in. And then on her final delivery day. Okay, so she had removable dentures, so like the plastic, for lack of a better word, like the plastic plates that you take in and out. That's not what they're made out of, but that's what patients refer to them a lot. And she was able to chew food. Aesthetically, they looked okay, and it gave her a smile back. Okay, so it's not brain surgery. It's a pretty standard thing that we make for patients. We make dentures all the time. Making dentures on a patient who can open 22 millimeters is a really hard thing to do. So it took a lot of time, and that was okay. All right, so follow-ups, she had follow-ups as needed, 6-month follow-ups to check just on her dentures and her soft tissue, and just to check on her joint as well. Okay, and then home care. We taught her how to care for her dentures. Recaps, what we talked about, right? Dry mouth, fibrosis, limited opening, challenges for all of us. How we can help you, and a few tricks outside the box, okay? This is your slide that you took from me, or that you shared with us in a much more articulate way than I can, so thank you, I'm teasing you. But again, it's not rocket science, right? It's really not. It takes time. Here's my personal order of the importance of these things. So number one is it takes time, it takes desire and caring, and it takes knowledge, right? But the knowledge is not, it's not anything that we don't get in dental school, right? So how to manage dry mouth, we could pull a second-year dental student from UIC and get them in that chair, give them the mic, and say, can you give me 3 ways to help fight dry mouth? And they would rattle off 7, right? If we ask someone how to, ways that we can help people with increasing their opening, or at least slowing down the progression of the limited opening, a second-year dental student would know about the popsicle sticks. They might not know about the Therabite, and that's okay, but they, the knowledge, it can be learned. It's the time and the desire, right? And so a lot of times we'll have dentists in the community call and ask about certain ways you can do it, and we'll set up a phone call and be like, hey, these are the most common things that we see in our patients. This is what we recommend, not that that makes it right or wrong, but this is just what we found, just because we might see patients with scleroderma a little bit more than people in the community, and then we'll work together. So we don't need to be the go-to place. We're happy to help anyone who wants to do it. And I'm Canadian. Maybe you can tell some of the words that I say like out and about, but so I've been very, very lucky to speak to groups in Canada related to the Scleroderma Foundation. And so I'll get emails from friends in Calgary and in Toronto and Montreal and be like, hey, what do you think about this? And send them stuff. So we could communicate through email, through Zoom, through whatever. You don't have to come to Loyola, right, is my main point. You can, we'd love to see you, but you don't need to. If it's hours away, if it's, a far trip, that's not necessary. Okay, we can help in other ways. Okay, there's my Canadian flag. So.